Hello and welcome to another episode of The Heart of the Jersey Shore. Today our special guest is Dr. Emad Groban. He's a nephrologist. Hard word to get out. So, welcome, doctor.
Hi Mike, how are you?
Very good. Well, I hope you're not nervous because we have a lot of questions we're going to ask you today.
I'll do my best.
Okay. So actually the first question is, what's a nephrologist?
Yes, very good question. So a nephrologist is a physician who specializes in kidney disease. So after finishing your medical school, you go for a residency, internal medicine residency. And some of these doctors who graduate internal medicine residency, they join fellowships to specialize in heart disease, lung disease, kidney disease. So a nephrologist is a physician who finished 2 years at least of nephrology training for kidney disease.
So that's after your regular medical school and residency?
Correct.
Ooh, that's a lot of years.
Yes. And some nephrologists also, after the 2 years of nephrology training, they go for 1 year of transplant nephrology. So they specialize in kidney transplant and so on.
Wow.
Yes.
That's heavy. So what does a nephrologist do actually?
Yes. So the nephrologist treats a wide variety of diseases, specifically diseases that are related to the kidneys, including but not limited to acute kidney failure, chronic kidney disease, electrolyte disorders, hypertension, which is a very big and very important part of our practice, treating and managing hypertension, prevention of kidney stones, and seeing patients in the hospital and outside the hospital. There is a lot of acute patients that we see in the hospital that requires nephrologist evaluation and management. If someone is admitted for severe infections or septic shock, or ICU patients that may require urgent dialysis and so on, they require to have a nephrologist on board.
Great. So this is a little redundant, but why would somebody come to see a nephrologist?
Yes. So we see a lot of patients coming to us basically to evaluate diseases like, for example, hypertension. If someone's blood work shows, if someone's blood pressure is too high or the blood work shows abnormal kidney function, they refer patients to us. By that specifically, I mean the creatinine that all doctors check routinely for our patients, the blood urea, electrolytes. So we go to the nephrologist when these numbers are abnormal. It's a sign that there is something wrong with the kidney function. And the earlier you see the nephrologist, the better. A lot of diseases we can detect early and try to manage and stop the progression of the disease early on. So on your routine blood work, when your primary doctor sees something abnormal, we should ideally refer to a nephrologist to have further evaluation.
So with electrolytes, electrolytes could act like a lot of different diseases, like major things when it boils down to just electrolytes?
Excellent question. So electrolytes disorder are so many. The most important ones are sodium problems, either sodium being too high or too low. And believe it or not, it sounds very simple or maybe a minor problem. However, some patients may show significant and severe symptoms from either one. For example, patients who develop low sodium in the blood, low sodium levels in the blood, can have fatigue, generalized weakness, gait disorder, recurrent falls, and passing out, confusion. And believe it or not, some patients in extreme cases may develop seizures because of low sodium in the blood. On the other hand, when someone gets dehydrated, and for other diseases also, sodium level may go significantly high and can give someone lethargy, confusion, like in cases of severe dehydration.
Right. Yeah, we've seen that. So, would chronic urinary tract infections affect the kidneys?
Yes, there is a link between urinary tract infections and kidney disease. On one hand, recurrent urinary tract infections, especially severe ones, may increase your tendency to develop more and more urinary tract infections. And some urinary tract infection can lead to kidney stones. There is a bacteria, a very common urinary tract infection that is caused by a bacteria called Proteus, and over time and recurrent infection can lead to what we call Strovit stone, kidney stone, staghorn calculus, and that basically it fills up the tubules of the kidneys from inside. And that can damage the kidneys on the long run. Also, some patients with urinary tract infection can develop more severe infection like sepsis, severe dehydration, confusion, changes in blood pressure, specifically low blood pressure. And that can affect the kidneys in a bad way. If someone with a urinary tract infection develops septic shock or severe sepsis, which is bacteria in the blood, can definitely lead to kidney failure acutely and worse.
Now, is this more prevalent in women since women are more prone to urinary infection, or is it 50-50 men and women?
So in general, urinary tract infection is more common in ladies than men, but I would take both seriously.
Okay, very good. Or not good for the people anyway. And does recurring kidney stones play a factor in the kidney disease? Like, can we do is there prevention for that? And what happens with people with Crohn's, since a byproduct of Crohn's is kidney stones?
Yes. So definitely the more kidney stones someone has, the more, I would say, to simplify it, more scarring to the kidney tissue. And the example I mentioned earlier, the staghorn calculus, is one of the extreme cases of kidney stones where the kidneys can be replaced by kidney stones from inside, and that damage the healthy kidney tissue and can lead to significant kidney disease, including chronic kidney disease, and some patients end on dialysis. Of course, there are preventive methods, prevention of kidney stones. Number one, you have to identify what type of kidney stones you have. So I advise anyone who passes or who has history of kidney stones, they should ideally strain the urine if they are in acute attack, and that stone should be tested, because it will guide treatment for years to come. But in general, there are calcium, most common stones are calcium stones, and prevention, number one, you need to increase the urine output significantly. You need to have dilute urine. It's not how much water you drink, but it is mainly how much urine we produce. So we target and we advise patients and tell them our goal is to have urine output of 2 to 2.5 liters a day. this is the minimum urine output. So if it takes you 3 liters to achieve that, then this is what we need to do.
Okay.
Need to
so
drink.
It's not just drink a lot, but
Yes.
you determine how much they really need to drink.
100%. We need to know the urine output, and this is the best guidance of whether you are actually doing a good job with keeping up with the fluids intake and water intake or not. Number 2, low salt diet. Low salt diet is definitely advised for patients with calcium kidney stones. Regarding the calcium intake or dairy products intake, we advise patients to have a moderate or average calcium intake. We do not restrict their calcium significantly, despite knowing that they have calcium stones. Because if you cut down your calcium to 0 or I would say take it to the extreme and avoid all calcium products, you may absorb more oxalates in your body. And that oxalates may create more kidney stones over time. You may excrete more oxalates in the urine. So everything in moderation, I would say. And we do what we call 24-hour urine collection. It's a litholink test, meaning we test how much urine the patient produces. And also the chemistry of the urine, whether that person has too much calcium, or whether the acidity of the urine is too low or too high. If someone has a lot of uric acid or a lot of oxalate in the urine. So there are medications we give to decrease how much calcium we secrete in the urine. And as a secondary good effect is to, once you have less calcium in the urine, ideally should have less calcium kidney stones.
So is there a better kidney stone to get, like one better than the other or one less dangerous than the other?
Yeah. In general, calcium oxalate, calcium phosphate, and uric acid stones are the most common ones. The worst one is definitely the staghorn calculus, the staghorn kidney stones, because it fills up the kidney from inside and definitely has a lot of scarring effect.
Now, could that be like they do with kidney stones, where you go into a whirlpool or something and they shoot them with something and make them explode?
Yes. So urologist. So the urologists are doctors who actually deal with the kidney diseases, but the surgical aspect of kidney diseases.
Okay.
And the urologists have different procedures they can offer, like lithotripsy, which actually like shock waves to break down the stones.
Right, that's what I was thinking of.
You're absolutely right. And the second thing is some patients may require cystoscopies, which is a scope that goes up the urinary tract, the passage, the tubes, the ureters, and they can sometimes break it from inside. Some patients may require draining tubes. If there is a blockage, if the kidney stones created a blockage and the urine is not flowing freely downwards, sometimes the kidneys swell up. We call it hydronephrosis. And to bypass this problem, there are tubes that can be placed from outside, percutaneous nephrostomies. But usually these patients are very sick, and we get them done in acute settings. Again, if there is an acute obstruction, kidney failure, and you need to relieve the urine and the blockage right away.
So what effect does kidney disease have on the body?
Yes, very good question, Mike. So in general, kidney disease or abnormal kidney function most of the time is painless. It's not like when I have high creatinine or high BUN that will give me pain or discomfort, at least at the initial stages of chronic kidney disease. So that's why it's very important to check your blood work frequently, because someone can have a disease going on for quite some time and he or she does not know about it. However, patients with advanced kidney disease, especially chronic kidney disease stage 5, when the toxins start to build up in somebody's body, to a degree that person may look toxic or lethargic, confusion, increased sleepiness. A lot of time itching is a sign that either someone is getting what we call uremic, meaning there's a lot of toxic substance in his body, or the electrolytes are very abnormal. But you know, I really wish that this will never be the case to discover a kidney problem, because early prevention, early detection should prevent progression to that extent.
Well, is there a particular place on the body that would itch, that would be like a trigger to you to know what to look for?
In general, it's generalized itching and very dry
Just
skin.
anywhere?
Anywhere, yes.
Okay.
Yeah, and one of the warning signs also is decreased urine output. If someone is suddenly or over time start noticing that the urine volume is getting less and less. So low urine volume is always a warning sign. It's either someone is retaining urine, holding urine inside and not able to pass it,
Right.
or the kidneys fail to the point that the kidneys are not producing urine anymore. So also we should be very careful about this. And
Right, because that's actually a crossover of other problems as well.
correct, especially men with enlarged prostate.
Yeah.
Extremely common, and you know, it is a very common problem also that periodically they don't empty their bladder completely, especially at night. They wake up frequently to go to the bathroom, and weak flow, interruptions, and hesitancy, which means that you kind of initiate, and it's hard to initiate urine, and there's a lot of interruptions, and so it's definitely a risk factor in a large prostate for urine retention and decreased urine output.
Right. Interesting the way things keep
Overlapping.
overlapping, yeah. So is there a major difference of kidney disease between men and women?
So not really. The diseases that can affect men can affect women and vice versa. But for example, preeclampsia and eclampsia, these are diseases that of course affect only women
Right.
during pregnancy and immediately after childbirth. In diseases like this, we see very high blood pressure, a lot of protein in the urine, sometimes kidney failure also, and that's it.
Wow.
Yeah.
Okay. So we touched on this a little earlier, which was hypertension and kidney disease. So hypertension is a result of kidney disease sometimes.
Right. There is essential hypertension, which is hypertension that does not have a specific reason. Sometimes it's genetics, atherosclerosis, but there are secondary causes of hypertension that we develop hypertension because of either chronic kidney disease or the vessels. We call it like renal artery stenosis, for example, that the vessels supplying the arteries supplying the kidneys get atherosclerosed, narrow, and a lot of times it's severe enough to create a hypertension problem. And these are fixable problems, meaning many patients can have stents or what we call angioplasty to open up the vessels, provide the kidneys with more blood supply. And many patients will have improvement in hypertension and also congestive heart failure. People who have recurrent congestive heart failure because of severe hypertension can definitely benefit from that. And there are also secondary hypertension that is related to hormonal disorders, and these also are treatable causes of hypertension. In essential hypertension, when someone's blood pressure is above 130/80, persistent, we tend to diagnose it with office visits, in addition to home readings also. And we combine those readings and make a decision to treat someone. That decision should not be rushed. One office visit with high blood pressure, I don't think justifies starting a blood pressure medicine.
I wouldn't think that either.
Especially with the white coat hypertension, which can be contributing to some increase in blood pressure during the office visit. But you have to take the average blood pressures. The patient and the blood pressure also has to be checked correctly during the office visit and at home. It is a very important part of our practice, treating hypertension in coordination with cardiologists and other specialties. We have a lot of new medications to treat hypertension, whether it's resistant or not. Now we have a lot of options.
That's good.
Yeah.
So things are getting better a little bit.
Yeah.
Okay, so now, diabetes and kidney disease.
Yes. Of course, millions and millions of people have diabetes. It's a very prevalent disease. One of the very common etiologies or reasons why someone can develop kidney disease. Early detection is a key. Diabetes affect the kidneys, the heart, the eyes, the feet. So as long as you're up to date with your annual exams, eye exams, blood work, and urine studies to detect early signs of chronic kidney disease, we check the urine for proteins, albumin, and usually it's a sign that there is stress in the kidneys or a problem in the kidneys that started to happen and show now. Also, along with the diabetes control, we have to control the uric acid level, the cholesterol, triglycerides, hypertension management. And again, currently there is a lot of medications we use to decrease the progression of chronic kidney disease over the years.
Just depends on where it's coming from.
Right. I mean, first of all, you have to focus on controlling your diabetes very well, controlling your hypertension very well. And there are, again, drugs, medications that we use to slow down the progression and avoid patients ending up in dialysis.
I heard that, certain medications affect the kidneys. People take pain medications and anti-inflammatories. So what effect does that really have on the kidneys, and what should be the frequency that people use these?
Yes, excellent question. A lot of these anti-inflammatory medications are over the counter, and you do not need prescriptions to purchase these meds. So very common, most of us use them at one point. But everything in moderation is okay, and you have to know where you are in terms of kidney function. If someone has no kidney problems, no stomach problems, no cardiovascular disease, yes, if someone has muscular pain or some shoulder pain, some arthritis pain, of course you can take it, but in moderation, and you have to ask your physician on the right doses based on your situation, based on your comorbidities. We advise our chronic kidney disease patients to avoid these medications because, again, to simplify it, they can hurt the kidneys and can show decline or can lead to decline in kidney function over time. Sometimes we react acutely to these medications, and patient can develop acute tubular necrosis or interstitial nephritis. It's like an allergic reaction and damage to the kidneys from these medications. So I advise you to consult with your physician before taking these meds, and the right dose will be determined based on the discussion.
Right, because a lot of people in the senior communities and the sports communities, they just plow this stuff like it's nothing.
Yes, that's very dangerous. Like taking a lot of these medications definitely has a bad effect, not just on the kidneys, but gastritis, gastric ulcers, cardiovascular disease. A lot of interactions between these medications and blood thinners, aspirin and other medications also. So you should be careful not just for the kidneys, but for the heart and your stomach and gastritis, avoiding these problems.
Wow, could get a lot of things.
Yes.
Okay, so now what is the relationship between kidney disease and congestive heart failure? Yes,
it's a very important axis, the heart and the kidneys. There is a big entity called cardiorenal syndrome. Different types of cardiorenal syndrome, patients with congestive heart failure who have low ejection fraction, low heart function, if the pump is not, pumping enough blood, I would say, to the rest of the body. A lot of times we see kidney failure because of that, either acutely or on the long run, and vice versa. Patients with a lot of kidney diseases, a lot of nephrotic syndrome, patients who develop a lot of volume overload because of kidney failure may push someone to have congestive heart failure. also. So we work in coordination with cardiologists, the heart doctors, to optimize the medications regimen to make sure we avoid the congestive heart failure from flaring up,
Right.
like fluid retention, shortness of breath, swollen legs, swollen abdomen. These are some of the signs that something is wrong and someone is actually in acute congestive heart failure. So we manage that problem, number one, by prevention. We don't want to reach that step, that part.
Right.
Number two, there's a lot of diuretics that produce urine, pushes the kidney or stimulates the kidneys to make more urine, to clear up the lungs from congestion, from excess fluids, and also decrease the swelling or the edema in the legs.
Right.
And we try to find the underlying reason why somebody went into congestive heart failure. Exercise, diet, low salt, restricting how much fluid somebody's drink may also help in some situations.
Okay. So once somebody is like they're in their kidneys, they've abused their kidneys, they're in kidney failure, they have to go on dialysis, is there a return from that? Or what leads up to the point where, well, you can't live without dialysis or you need a transplant?
Yes, excellent question. So many patients who got acutely sick and ended up in the hospital, in the ICU with a major problem, whether it's infection, bleeding, and they ended up on dialysis because the kidney stopped working temporarily. Those patients may end up recovering and coming off dialysis at one point. So if someone has good kidneys and good kidney function and developed a major problem that led to kidney failure and dialysis, they have like 50-50 chance, to simplify the idea, of coming off dialysis. Some patients come off dialysis after a week on dialysis, after a few days, after a month or two on dialysis, and sometimes longer. Patient showed some signs of recovery and to the point that we can take him off dialysis gradually and monitor them very closely to assess whether they should be placed back on dialysis or not. We have many success stories, and we have many patients who actually came off dialysis and remained off dialysis for years. This is one part of the problem and the discussion. The other part of the discussion is people who had hypertension, diabetes, congestive heart failure, or underlying intrinsic kidney disease, nephrotic or nephritic syndromes that led to progression of chronic kidney disease to stage 5. So we monitor those patients very closely, especially towards the end stages, stage 4 and 5.
Right.
And we base our decision to start dialysis not just based on the numbers that we see every time. Of course, that's extremely important. If the blood urea, nitrogen, and the creatinine are very high, the potassium is too high, not responding to medications, or if someone has a very acidic blood or other electrolyte disorder also, then we make our decision based on what we see. But also clinically, how the patient is presenting, behaving, how is he talking to you, how is he eating, his appetite, whether he's retaining fluid or not, whether he's still producing urine or not. That also dictates when to start dialysis. Some patients come into the office with high creatinine, high BUN, but they still feel perfect. So we monitor them very closely and try to postpone that process and get them ready for dialysis. There are two forms of dialysis. Dialysis that is done in a center, in a clinic,
Right.
3 times a week. And there is home dialysis that can be done also, either hemodialysis at home or peritoneal dialysis, which is done through a catheter in somebody's abdomen. And for peritoneal dialysis, patients do the dialysis themselves, a lot of time overnight, but every single day. And they function very well afterwards. And there are so many patients who are perfect candidates for peritoneal dialysis, and they are functioning, working, and sometimes playing sport also.
Yeah, because people hear, okay, you're going to be on dialysis, that's the end of your life.
No, the dialysis saved lives. A lot of time it's a good transition to stabilize someone and bring that person out of the ICU and get him out of critical condition to a point where he can recover, and it's a second chance to reassess the situation and give somebody a chance to heal. And again, a lot of patients may come off dialysis if it happened acutely. Maybe not, but we try to be optimistic and encourage patients to fight and stay optimistic. And the outpatient dialysis and the peritoneal dialysis at home, it is doable. And again, we have so many patients who are very functional and very active.
That's good to hear.
Yeah.
So basically, it's just like you're not going to feel if you're getting kidney disease. Possibly.
Yes. Initially, if it's a minor increase in the kidney test, you may not feel anything. You may not feel anything for a very long time. Problem happens when suddenly the blood pressure either go too high that prompt that person to go to the hospital or go to a doctor to check, or changes in appetite or headache or nausea, vomiting, decreased urine. Some patients just come and tell me, I feel a little off. I have not seen physicians for like 10 years. And now something is wrong. I don't know what it is, but I feel weak, tired. I'm not performing like before. I'm not active like before. We check blood work, and unfortunately we see very, very advanced kidney disease.
And that's the problem, because people feel fine, they go about their lives, and they're really hurting themselves by not going to a doctor regularly, not having all of these things checked.
Correct.
Until maybe they're in their old age, and sometimes it's too late.
Correct. The high-risk population is patients who have family history of kidney disease, strong family history of kidney disease, dialysis patients in the family. Number two, patients who have long-standing hypertension and diabetes, either or. Patients who have HIV, hepatitis, patients who had major events, major health scares in their lives, severe infections, septic shock, patient who had recurrent stones, kidney stones, patient who take a lot of anti-inflammatory medications, people who have received a lot of contrast materials, contrast for injections, for CAT scans, cardiac cath. A lot of people have emergencies and they receive contrast after another. So
never thought of that one.
Yeah. So the best thing is check with your primary doctor routinely. If you are a diabetic, you need blood work. Also, you need urine studies to check for early signs of kidney disease, specifically protein in the urine. And make sure you hydrate yourself well. Do not take medications, even over-the-counter medications, before consulting with your doctor. And I believe everything in moderation is okay, as long as you consult with your doctor that knows your comorbidities.
That's great. Well, this is definitely has been an enlightening conversation.
Thank you.
And I really think that our viewing people, audiences, are really going to get a lot out of hearing all of this.
Thank you. I enjoyed being here with you, and thank you for having me.
Thank you so much as well.
You're very welcome.
So this is Michael Blank, KLVW, the heart of the Jersey Shore. Until next time.